Hey y'all, this is Cami. Today I'm going to talk about a few selected respiratory and digestive system abnormalities that can be seen in embryology. I've listed 5 learning objectives here for you, as these will encompass the test questions at the end of the presentation, so have these in the back of your mind as we go through. I want you to be able to identify the most common form of esophageal atresia, recognize a few postmortem findings associated with neonatal respiratory distress syndrome, understand the embryological basis for congenital hiatal hernia, recognize clinical presentations that are associated with pyloric stenosis, and lastly, understand the consequences of extrahepatic biliary atresia if left untreated. And this image you see here is just a cool x-ray of an infant with esophageal atresia, and I love x-rays, so any chance I get to throw one in, I definitely will. All right, so let's get into it. We're going to start off by discussing the formation of the lung buds, as this applies to our first congenital abnormality, esophageal atresia and tracheoesophageal fistula. So we've already learned that approximately around 4 weeks, the lung bud, aka respiratory diverticulum, which you can see in both images here as the bright blue structure, makes its appearance. And it's an outgrowth from the ventral wall of the foregut. The lung bud's appearance and location is actually dependent upon an increase in retinoic acid, which is produced from the mesoderm. This increase in retinoic acid then upregulates TBX4, a transcription factor that is located in the endoderm of the gut tube at the lung bud site. TBX4 is what actually activates the lung bud to form and also is responsible for the continued growth and differentiation of the lungs. And this is why the epithelium of the larynx, trachea, bronchi, and lungs are of endodermal origin, and the cartilage, muscle, and connective tissue of the trachea and lungs are of visceral mesoderm. So, originally, the lung bud has open communication with the foregut, but eventually the lung bud expands caudally to create 2 tracheoesophageal ridges that will separate it from the foregut, which you can see here in this image. These ridges will then fuse, creating a tracheoesophageal septum, which then divides the foregut into the esophagus dorsally and the trachea ventrally. We see this in this image here with the now independent esophagus and trachea. So here's where we'll get into our first congenital abnormality, because if there are any issues with this esophageal tracheal separation, an esophageal atresia with or without a tracheoesophageal fistula will develop. Simply put, an atresia is a portion of the esophagus that fails to develop, such as the upper segment being disconnected from the lower segment and stomach. So this is going to leave a thin, non-canalized cord that will result in mechanical obstruction. Atresias are usually associated with the fistula, but they don't have to be. A tracheoesophageal fistula being the upper esophagus abnormally connecting to the trachea. I like this image here because it shows you all the different types of esophageal atresia and or tracheoesophageal fistulas, which is really wild, so you got to give thanks to your normal functioning anatomy. And it's comparing this to our normal anatomy, which we already know, but the most common form, about 90% of cases, is going to look like that second image labeled atresia with distal fistula, where the upper esophagus ends in a blind pouch labeled atresia and the lower segment forming a fistula with the trachea. Interestingly enough, any developmental issue with the esophagus can be associated with a range of other congenital anomalies, which is known collectively as VACTERL, which represents malformations of the vertebrae, anus, cardiac, tracheoesophageal fistulas, esophageal atresias, renal system, and limbs. Esophageal atresia occurs in approximately 1 to 5 infants per 10,000 live births and is most commonly seen at or near the carina, the branching point of the primary bronchi. And as I previously mentioned, the most common form is going to result in the form that is depicted here as image A. Esophageal atresias are going to be discovered shortly after birth due to regurgitation after feeding as the first clue. And naturally, this serious defect can have serious consequences if not dealt with. For example, if gastric contents or amniotic fluid enter the trachea through that fistula, pneumonia can develop. Aspiration, suffocation, and polyhydramnios are also possible consequences. So after seeing the abnormal anatomy, it makes sense that esophageal atresias and tracheoesophageal fistulas are incompatible with life unless immediate surgery is performed. So as a forensic PA, this is something we could see at autopsy, and we would see any of those forms I had previously shown, and possibly with any of the VACTERL abnormalities I had listed. So this image is from an infant's autopsy which is demonstrating a few different things, including a congenital laryngeal and upper tracheal atresia below the vocal cords, esophageal atresia with tracheoesophageal fistula, agenesis of the mid-esophagus, so lack thereof, and a fistulous connection between the distal esophagus and carina. Next, I'm going to discuss neonatal respiratory distress syndrome, so I need to briefly talk about lung development and maturation first, and I'm only going to highlight key points of tracheobronchial tree development. We've already discussed how the lung bud forms the trachea, and from that point on, two lateral outpocketings are going to emerge and form the primary bronchial buds, which you can see in this image here. Then the buds are going to enlarge at the beginning of the 5th week and form the right and left primary bronchi. From there, we know that the right side will form 3 secondary bronchi and the left will form 2, corresponding with the correct number of lobes on each side. Secondary bronchi then divide repeatedly to give rise to tertiary segmental bronchi, 10 on the right and 8 on the left. Bronchioles are going to continuously divide into numerous and smaller canals up to the 7th month, giving rise to terminal bronchioles, which divide to form respiratory bronchioles, which will then further divide into alveolar ducts, which will end with primitive alveoli. So it's by the end of the 7th month where mature alveolar sacs and capillaries are present in sufficient quantities to guarantee adequate gas exchange and premature infant survival. And interestingly enough, before the bronchial tree can reach its final form, 6 more divisions need to occur after birth. The alveolar period, where mature alveoli will have well-developed epithelial capillary contacts, is from 8 months and into childhood, but mature alveoli are not actually present before birth. The alveoli themselves are lined with endothelial cells, type 1 pneumocytes and type 2 pneumocytes, which are the cells of interest when discussing neonatal respiratory distress syndrome. And this is just a really nice diagram of some key points I talked about, including brief definitions of esophageal atresia and neonatal respiratory distress syndrome. All right, so NRDS is an acute lung disease of the newborn caused by a surfactant deficiency, which is seen in premature infants and is the most common cause of respiratory failure and accounts for 20% of deaths amongst newborns. So around the end of the 6th month, type 2 alveolar pneumocytes develop, which are the cells responsible for producing surfactant, which is a crucial phospholipid-rich fluid that lowers the surface tension of the air-alveolar interface. Without it, alveoli simply collapse during expiration because the tension becomes too high, and you can see that depicted in the image here showing normal versus collapsed alveoli, and how surfactant really is this fluid that is just coating the internal surface of the alveoli. So surfactant is secreted 24 to 26 weeks of fetal life, but doesn't start to accelerate until after the 35th week. This is why premature infants with insufficient surfactant will suffer from NRDS. There can also be a gene mutation in the SFTPB or SFTPC genes, which results in a congenital deficiency of surfactant. There are different components of surfactant that play different roles. We have hydrophilic glycoproteins SPA and SPD that play a role in innate immunity, while hydrophobic surfactant proteins SPB and SPC are responsible for reducing alveolar surface tension. At birth, the first breath requires a really high inspiratory pressure in order to expand the lungs. The lungs will retain 40% of the residual air volume after that first breath when normal levels of surfactant are present, ensuring that each subsequent breath requires much lower inspiratory pressure. During that first breath, air travels to the surfactant-coated alveoli and prevents an air-blood interface from developing. Surfactant reduces the surface tension in the alveoli, so less pressure is required to keep them fully aerated. This is why the lungs will collapse with each subsequent breath if there is a surfactant deficiency, and the newborn has to work really hard with each breath, just as hard as they did for that first one. This can then lead to the lungs collapsing, severe oxygen deficiency, and carbon dioxide retention. And you can see in this flow chart here that a whole list of downstream effects can occur from that point on. Surfactant synthesis is actually under the control of an array of hormones and growth factors such as TGF-beta, insulin, cortisol, and glucocorticoids, and glucocorticoids have a particularly important role as increased amounts actually lower the risk of developing NRDS. And diabetic pregnant women have a higher risk of developing NRDS because high blood levels of insulin in the infant, which are caused by the high blood glucose level of the mother, will actually suppress surfactant synthesis because it counteracts the effects of glucocorticoids. Another risk factor for NRDS is cesarean delivery before the onset of labor, because labor increases surfactant synthesis, so I thought that was really interesting. The clinical presentation of a newborn with NRDS includes a smaller sized body with a disproportionately large head as they are preterm, but their weight is appropriate for gestational age. And apparently there's a stronger association with males. They may have to be resuscitated at birth, but normal breathing and color typically comes back within a few minutes. Within 30 minutes, however, breathing becomes very difficult and the newborn can become cyanotic within a few hours if untreated. They'll hear what's called fine rails in the lungs, which has been compared to the sound of wood burning in a fireplace. So you hear these high-pitched popping lung sounds. And a chest radiograph reveals a ground glass picture of the lungs with these small reticulogranular densities, which is what this image is showing here. So the prognosis and treatment varies depending on how mature the lungs are, what the birth weight of the newborn is, and how quickly the hospital starts therapy. Prevention strategies are the focus, though, such as delaying labor if possible so the lungs can have time to fully mature, or by inducing antenatal steroids to the fetus. If, however, those things cannot be done or were not successful and the baby is born with NRDS, ventilation, artificial surfactant, and glucocorticoid treatments will be put into place, and there's a great chance of recovery if therapy is successful for 3 to 4 days, meaning if the newborn can survive past 3 to 4 days. But relating this to the pathologist assistant field, we know that this syndrome accounts for a good percentage of fetal demise. So on gross examination, the lungs are distinctive in that although they are of normal size, they are solid, airless, reddish purple, similar to the color of a normal liver, and sink in water due to the absence of entrapped air. So both of these images were taken at autopsy from infants with NRDS. The top image is showing small collapsed lungs with a focal hemorrhage at the white arrow, and the bottom shows us that red-purple coloration and consolidation quite nicely. All right, moving on to congenital diaphragmatic hernia, which we first need to briefly discuss the formation of the stomach and esophagus in order to understand this abnormality. So during the 4th week, the stomach develops from the foregut, beginning as a fusiform dilation, and then it changes positions, sizes, and shapes. The stomach rotates 90 degrees clockwise around its longitudinal axis, which we can see here in this image. So its left side faces anteriorly and its right side faces posteriorly. During this rotation, the posterior wall is going to grow faster than the anterior, which forms the greater and lesser curvatures. The stomach will rotate around the anterior-posterior axis, allowing for the pyloric part to move to the right and upward, and the cardiac part to move to the left and downward, and the stomach is now in its final position. In order for the stomach to be correctly positioned in the abdominal cavity below the diaphragm, the esophagus must lengthen. Failure to do so will result in a congenital diaphragmatic hernia, and the stomach remains in the thoracic cavity, obviously abnormal and obviously an issue, and that's going to compress the lungs. Congenital diaphragmatic hernia is where part of the stomach and small intestine herniate through the esophageal hiatus, which is the opening in the diaphragm that allows the esophagus to enter the abdominal cavity. Congenital diaphragmatic hernia is in the region of the lumbocostal trigone of the diaphragm, and it's going to enter into the thoracic cavity and is most commonly seen on the left side due to the liver on the right. And I highlighted the lumbocostal trigone area in this image here from Netter, and we can also see the esophageal hiatus. So the prenatal space of the pulmonary cavity is obviously quite limited, so if abdominal contents are occupying it, in this case the stomach and small intestine, one lung, usually the left in these cases, doesn't have room to develop normally or inflate after birth, which accounts for the very high mortality rate in these infants, around 76%. Given that, as a forensic PA, we would be seeing these findings post-mortem. And there's a great image here displaying a congenital diaphragmatic hernia occupying the left pulmonary cavity. All right, on to our next topic, pyloric stenosis. As I previously discussed, the stomach rotates 90 degrees clockwise, and a series of events take place that form the greater and lesser curvatures and the pyloric and cardiac regions. So if the circular and longitudinal muscles, mostly the circular though, of the pylorus become hypertrophic, pyloric stenosis results, which is defined as the extreme narrowing of the pyloric lumen, so the passage of food is blocked, resulting in severe projectile vomiting, which we can see in that top image here, which makes sense because there's no other route for ingested substances to go at that point. There have been a few cases where pyloric stenosis is due to the complete absence or closure of the pyloric orifice as well. So this is a common abnormality of the stomach in infants, having an overall incidence of 1 every 300 to 900 births and is 3 to 5 times more common in males. Most cases are going to present about 3 to 5 days after birth as a new onset regurgitation after feeding, with projectile vomiting and increased demands for feeding. Interestingly enough, there is an increased risk in twins, patients with Turner syndrome and trisomy 18, and erythromycin or azithromycin exposure. That mechanism is still not understood, so further research into that would be cool to see. There's a visible abnormal abdominal bulge that moves from left to right after feeding and right before projectile vomiting. And the top image shows an infant with pyloric stenosis and that abdominal mass. The majority of cases, about 90%, present with a firm ovoid 1 to 2 centimeter abdominal mass. Diagnosis is primarily made by ultrasonography, and the bottom image here is showing exactly that in a 6-week-old, and we can see that post-feeding, the pyloric orifice is still closed. So this is curative by means of surgically splitting the muscularis propria. In relating this to the pathologist's assistant profession, then, I'm thinking we could receive parts of the muscularis propria that were removed during surgery. All right, so lastly, I'm going to talk about biliary atresia. In order to understand this condition, we'll first talk a little bit about the formation of the bile ducts. So the formation of the liver begins in the middle of the 3rd week as an outgrowth of endodermal epithelium to form the liver bud. From the foregut, the liver bud and duodenum are connected, and cells go through the septum transversum, which narrows the connection between the two to form a bile duct. The cystic duct and gallbladder are formed by a ventral outgrowth of the bile duct. Hepatic cells are going to start forming bile around the 12th week, and bile will flow from the hepatic duct to the common bile duct to enter the descending segment of the duodenum. Bile is very important as it aids in the emulsification of fats, eliminates bilirubin, and neutralizes stomach acids before food enters the ileum. Biliary atresia is a type of obstructive biliary disease where the ducts fail to recanalize for whatever reason, so the flow of bile is obstructed. Biliary atresia can be either extrahepatic or intrahepatic, as we see displayed in these images. So intrahepatic bile ducts obviously being those ducts within the liver itself, whereas extrahepatic bile ducts being outside of the liver, so the common bile duct, common hepatic duct, and cystic duct. Intrahepatic biliary atresia is rare, accounting for only 1 in 100,000 live births, and can be fatal but typically runs a benign course. Extrahepatic biliary atresia, the more common form, accounts for 1 in 15,000 live births and is seen as either complete or partial obstruction within the first 3 months of life. Around 15 to 20% will have open proximal ducts and correctable defects, but the vast majority will die unless they receive a liver transplant. The cause is actually unknown, but various causes such as autoimmune damage, infections, and toxic agents have all been implicated. Newborns with biliary atresia will present with jaundice, as we see in the top image here, hepatomegaly, dark urine, and clay-colored stool. As I mentioned earlier, surgical intervention and/or a liver transplant is required. If left untreated, liver cirrhosis will develop within 3 to 6 months. Relating this to the PA profession, we could receive a liver explant at the bench, which would present as a rock-hard and dark green liver, or we could see those findings at autopsy. So that bottom image there came from a 3-month-old who died of extrahepatic biliary atresia, and you can see that dark green coloration. All right, so my questions for you are, what is the most common form of tracheoesophageal atresia? What are some postmortem findings for patients with NRDS? In congenital diaphragmatic hernia, what causes part of the stomach and small intestine to be pulled through the esophageal hiatus? What are some clinical presentations that are typically present for a patient with pyloric stenosis? And if left untreated, what is a severe consequence of extrahepatic biliary atresia? These are my resources for content, and these are my resources for the images I used, which were a lot. Thanks so much for listening, y'all. Be well.